Hello, everyone. We are in this new series of CVIR where we meet the authors of the articles that are published in our journal. And today I have Sara Silberstein from Albany Medical College. And she's the author of a very interesting publication entitled Ethics in Interventional Radiology. So this created a lot of interest in our readership, and myself as assistant editor of CVIR, I'm here with her today to ask some questions in order to clarify some ethical aspects of IR and what do IR need to be prepared, as a clinical specialty. Do you think that because IR is a bit less invasive than surgery, is subject to some pressure, so other specialties might think that whatever we do is like a little thing, a minimal invasive thing? So I mean, a surgeon would not be receiving a lot of pressure to operate or do a big operation, whereas ourselves in our clinical practice might be being considered minimally invasive. This is something that can be even accepted, even if it's futile. And do you think there's a cultural perspective? So would some cultures accept going a little bit over the line, for interventions for sometimes, or other cultures would probably say this is time to stop and anything that is done, and we don't need to do anything more for this patient? Is that the case?
Yeah, those are both really interesting questions because they bring up some really interesting perspectives that patients might have. When patients hear minimally invasive, they might be thinking something completely different than surgery. And lo and behold, they end up in what probably looks like a regular OR to them. And they still will experience discomfort. Minimally invasive doesn't mean it's pain-free. It doesn't mean it's fun. And to the extent that their referring clinicians are well informed about what IR does, then that can really help facilitate good patient decision-making and that shared decision-making. But when you have other clinicians in the hospital who don't fully understand what goes on in the angio suites, then that sort of starts the conversation off in a potentially tenuous way where there might be more room for misconceptions from the patient side. And then, it's up to the IR team to do a little more work of really helping them understand what this will look like. So, I don't know if we are subject to more ethical dilemmas because of that, but I think we certainly have to really focus on how we communicate to the patients what we do, because there's probably less of a baseline knowledge from the layperson about what interventional radiology is. And then in terms of the cultural perspective, I think you bring up a really good point, because from what I understand, in America, we have a very life-preserving sort of goal and culture and perspective, and are willing to go to great lengths to preserve life at the expense of quality time, at the expense of quality life, and potentially at the expense of patient autonomy sometimes. And I have a hunch, without seeing IR work in other countries, I have a hunch that this is a probably large difference when you compare IR discussions about futility and palliation and what we're willing to do in America versus other countries across the world.
And what about consent? So, because we mentioned that, probably other specialties don't know exactly the details of what's happening in the angio room and would not be in position to understand the risks potentially. Would they be in position to consent the patient, to obtain consent from the patient? Who should perform the consent and when? How close the procedure?
The consent, when we talk about consent, it sort of has two faces. There's the legal aspect where we're signing the document and we're making sure that legally we are covered and we have appropriate documentation. And then there's the meat of consent, which is what is the patient actually getting out of this conversation? Do they understand that they have the option not to do this? Do they understand what will happen if they don't do this? And do they understand risk benefits, alternatives, and hopefully are prepared a little bit to understand what the procedure will be like and who best equipped to do that, but someone with operator experience. At least in the US and from what I've seen, this is difficult. I think this is difficult for any specialty when you have a practice that is very busy and relies on trainees. So in the States, relies on residents to help work up patients. And they might not have as much experience as attendings in operating in those procedures. But, at some point we have to learn how to have these conversations and we have to go through this. But I don't know if there's enough emphasis put on the fact that this is a really important conversation that is an art and it takes practice. And, it's not just something that you're good at on day one, even though we graduate medical school and on day one, we're expected to be proficient at it.
And part of what we do in IR is also linked with industry. So in the whole ethics spectrum, it's not only the decision making and the capacity and the consent and whether the futility or not of intervention, but also if you have commercial influence, commercially biased decisions. There's a huge ethical the framework regarding the complications that might occur. How would be this somehow IRs how can safeguard their practice, and avoid any problems with that might arise from commercial bias? What do you think on that?
Yeah, I mean, this is physicians have an interesting relationship with industry, and that looks different in different countries as well, right? But disclosure, always disclosing to the patient personal biases, industry biases, and connections, whether it's research, whether it's something a little less formal. Disclosure. Time and time again, we've shown that outcomes for physicians in terms of how much they get sued, and the patient relationships are better with honesty, right? So always being honest and upfront, but that also takes an awareness. It takes an awareness of these biases that might be a little more subtle than, oh, I am conducting a research project with in collaboration with this commercial company. So it takes a self-awareness, one, to really say, is this impacting my decisions? Is this impacting how I talk about product A versus product B to a patient? Even going as so far as to look at objective data and see in practice, how many times have I used this agent versus the second agent?
This is fantastic. Thank you very much for sharing your article to CVIR. Thank you very much for sharing your experience and your views with on this video for the CVIR readership and the more extensive IR readership. Thank you, and we would encourage you to submit more articles like this in the future in CVIR.